Good morning to all. Today's topic is on resective osseous surgery. Learning outcomes are at the end of the topic the student should be able to explain the terminologies used in osseous resective surgery, list for steps in osseous resective surgery, describe the indications and outcomes of osseous resective surgery, and finally summarize the modifications in osseous resective surgery. So coming to the definition of osseous surgery given in Karansa, that is, this is defined as a procedure by which changes in the alveolar bone. So we are making changes on the alveolar bone to get a physiological bone form. So this can be accomplished to rid it of deformities induced by the periodontal disease process or other related factors such as exostosis and tooth eruption. Okay, so Dr. Sol Sugar in 1949 known to be the father of resective osseous surgery. So in World Workshop of Periodontology in 1989, so defines the osseous surgery as that the aspect of periodontal surgery which deals with the modification of the bony support of the teeth. So the mainly the pocket elimination. So we studied about all the periodontal surgeries to remove the pocket. Actually, the total pocket elimination could be maintained only with the removal of bony content of the pocket. So this is basically reshaping the bone to a physiological form. So then coming to the osseous surgery, what is osseous surgery? We already learned about it, and what are the types of osseous surgery, and how can we attain this physiological form? So when we tell about the details of each, this can be either additive osseous surgery, that is meaning that is the formation of bone, that is a regenerative periodontal surgeries will be done to additive, that is to adding the bone, that is a additive osseous surgery, and the other one is that there is subtractive osseous surgery. So additive osseous surgery is something that is regaining or restoring the alveolar bone to its original level, whereas subtractive osseous surgery, that is, or a resective, it is called as resective osseous surgery, that is what we are dealing with it today. So it is the that is designed to restore the form of pre-existing alveolar bone to the level present at the time of surgery or slightly more apical to its level. So we are just actually reshaping the bone to a favorable form for the periodontal maintenance. Okay, so this can be of two types, that is what we told, there is the osteoplasty and ostectomy. Okay, so this is the two procedures, osteoplasty and osteotomy. Actually this was basically proposed by Friedman in 1955, and that is mainly to shape the bony defects. Bony defects already you have studied, there is a Goldman Cohen given the classification for bone defects. So mainly the selection of treatment technique will be based on the number of intra-bony walls, that is a one wall defect or whether it's three wall defect. So treatment basically based on the type of bony defects. So that we will go to the details later. So as we told before, what is additive osseous surgery and what is subtractive osseous surgery? As we told, so this is that is this surgery, that is additive surgery is the surgery that includes procedures directed at restoring the alveolar bone to its original level. That is the regenerative periodontal surgery. That is we are keeping bone grafts. Mainly it is used in three wall bony defects. So we will be keeping bony grafts, membrane to restore the alveolar bone to its original level. Whereas subtractive osseous surgery, we are designed to restore the form of pre-existing alveolar bone. Okay, not to the original level. So we are just restoring the form of pre-existing alveolar bone to the level present at the time of the surgery or slightly apical. So we are just reshaping or recontouring, making it favorable in a way to have proper periodontal maintenance, oral hygiene maintenance. Okay, so that the two surgeries, so there is a two techniques that is coming under osteoplasty and ostectomy. So one or both of these procedures can be used to produce the desired result. Okay, so that is the osteoplasty. So what is osteoplasty? This is the plastic procedure in which there is osteoplasty, there is the osseous surgery in which periodontal pocket is eliminated and the bone reshaped to achieve physiological contour of the bone and the gingiva overlying it. There you know there is a plasty meaning the shaping. There is gingivoplasty also we studied, there is the shaping of the gingiva. So this is the shaping of the bone. So this will be without removing tooth supporting bone. Whereas ostectomy or osteotomy is the procedure in which bone that is part of the attachment apparatus will be removed to eliminate the periodontal pocket and will establish gingival contours that will be maintained. Okay, so this is by the removal of two supporting bond, we are getting a favorable osseous contour. So coming to the rationale of osseous surgery, as you know that the main goal of osseous resective surgery is to reshape the marginal bone to provide a more physiological bone contour. So why do we need to do this reshaping to provide a more physiological bone contour? As you know, the gingival contour is closely dependent on the contours of the alveolar bone as well as the proximity and the anatomy of the adjacent tooth surfaces. So the elimination of soft tissue pockets alone will not help to remove the pocket fully or to eliminate the disease fully. So we need to combine this procedure with osseous reshaping and elimination of osseous craters and angular bone defects to establish and maintain shallow pockets and also optimal gingival contour. So always this periodontal disease, it will lead to discrepancies in the level and shape of the bone. So you can see that this is a normal contour, that is a gingival contour, tissue contour will be following the bone contour. So during the disease status, you can see that there is amount of like bone loss or the bony defects uh, will get uh, will get occurred. So you can see that this is the difference between there is A and B. It is mentioned like the width between A and B. There is bony discrepancies. So you can see that even after the removal of soft wall, there is a pocket elimination. This is staying. So this bony defects is still there. So this will help to return the pocket depth. So that is what there is a need of pocket elimination. There is a soft tissue procedures, periodontal flap surgeries along with the osseous reshaping. So this help in regaining or eliminating the pocket depth and to promote periodontal maintenance. Okay. So coming to normal alveolar bone morphology. So what is normal alveolar bone morphology? So it's very important to perform resective osseous surgery correctly. There is a scalloping depends on both tooth and tooth root form, tooth position and the alveolus. So always a normal architecture will be like this. There is an interdental bone will be more coronal than the labial, lingual or palatal. So you can see that this is a normal structure. So this will be based on tooth form, embrasure width, and it will be more tapered. It will be more pyramidal, and if it is wider, then it will be flat. So there is a form of interdental bone. Okay. So the position of bony margin always makes a contours of the CJ. The scalloping will be more in case of anteriors than posteriors. So always the position of bony margin mimics the contours of the CJ. So it will be more scalloping in case of anteriors compared to posteriors. So coming to different morphologically descriptive terms that you can see that positive architecture, negative architecture, flat architecture, ideal osseous form. So relative, this is the diagrams showing. So the first one, that is the positive architecture, that is, there is the architecture, there is a buccal and lingual radicular bone will be more apical than the interradicular bone. That is the positive architecture. What is negative architecture? Negative architecture is that the interdental bone will be more apical to the buccal or palatal or lingual radicular bone. This is also called as reverse architecture. Okay, the other one is positive, this is negative. So it is also called as reverse architecture. Then what do you mean by this flat architecture? Whereas this both interdental and radicular bone will be at the same height. Okay. And then coming to the ideal osseous form, that is considered ideal. That is when the bone margin of the proximal surface is consistently. That is what we are achieving. So we will be like by removing of bone, we will be achieving this type of bony architecture. That is the there is the interdental proximal bone margin will be more coronal than the facial and lingual surface. So this is the form that is desired after periodontal surgery. Okay, so we told about the osseous reshaping. So this can be of two types. Just I want to just tell the um, till the meaning of this definitive osseous reshaping and compromise reshaping, you can just go through it. That is definitive osseous reshaping. That is implies that further osseous reshaping would not improve the overall result. So that is they have done the definitive osseous reshaping. So there is any further it is not going to help. So will not going to improve the overall. So that is definitive osseous reshaping. So what is compromised osseous reshaping? There is any reshaping that is leading to the there is more compromised effect to the to the result. That is what it is compromised osseous reshaping. Indicates a bony pattern that cannot be improved without significant osseous removal. There would be detrimental to the overall result. So hereafter we cannot do anything. So that will be detrimental to the overall. So there is a compromise type. So this is the two types of osseous reshaping. If you want, you can go through it. Otherwise, it's not that much important. I just want to describe what it is. Okay, what is definitive osseous reshaping and what is compromised osseous reshaping. So coming to the important part, what are the indications of osseous resective surgery? There is it can be used, first of all, I want to tell that it can be used only for early to moderate bone loss. It will not be used for advanced bone loss. Okay. So with the deep multi defects, they are not good candidates for resective osseous surgery. So they can be better treated with regenerative therapy, combining this osteoplasty or osteotectic to reduce bony ledges and to facilitate flap closure more appropriately with new attachment and regenerative procedure. Okay, so then coming to the indications, that is shallow, moderate one wall or two wall osseous craters. That is the most common osseous crater. That is the main indication for it. So shallow to moderate one wall or two wall craters, it will not be used for advanced bony defects. Other than that, it can be used for existence of non-supporting bone. So if any non-supporting bone that is hindering the flap adaptation, this can be used. Then irregularity of bony morphology, that is in case of hemisection or root amputation, you can remove bone. Okay. That is for root amputation also. Any irregularity of bone morphology, if it is occurring after that, you can remove it. Then shallow intrabony defects. That is what we told before. That is with sufficient periodontal support. With shallow intrabony defects, you can go for this osseous surgery. And irregular bony condos, if that forms the outer wall of pocket. So if there is any irregular bony condos that forms the outer wall, that can be removed. Then the residual osseous defect, especially what we told before, that is after regenerative therapy, after the bony graft in three wall defects also, if we are keeping bony graft, some amount of residual osseous defect, if it is there, it can be removed by this osseous surgery. And in case of deep caries or fracture, there is extending subgingivally to alveolar bone, we need to remove some amount of bone to get access to caries. So this can be done. Aesthetic purposes or clinical crown lengthening. So for crown lengthening, we need to expose some amount of tooth structure, that is for restorative or prosthetic treatment. Then this crown lengthening should be done. That is osseous reshaping will be done to expose more amount of tooth. Okay. Then furcation involvements. In case of furcation involvements, for making it periodontal maintenance, in case of tunneling, so all these procedures we will be removing the bone. So that is also done. So these are the indications for osseous resective surgery. So the main indication is shallow to moderate. Other than that, existence of non-supporting bone. In case of flap adaptation, irregularity of bone morphology related to hemisection or root imputation, shallow intrabony defects with sufficient periodontal support, irregular bony conduits that form the outer wall of pocket, residual osseous defect after regenerative therapy, deep caries or fracture in case of aesthetic purposes, and furcation involvements. Okay. So coming to the bony defects. So we already studied about these bony defects. I just want to give a brief description to know about the bony defects and to direct to the procedure what we are going to do. Okay. So you know that supra bony defects, intra bony defects. This can be horizontal bone loss and vertical type of bone loss. In case of infra bony, we will have different types of intra-bony defects, that is, it can be 3-wall defects, 2-wall defects, and 1-wall defects. So this is the best diagram you can really go through, that it is very clear in these three diagrammatic representations. So it will be very clear that which procedure will be apt for each type of bond defects. So in case of 1-wall defect, you can see that the number of volts present is only 1. So in case of this regenerative technique will not be useful, so that it can be used for resective osseous surgery. Okay, there is a 1-wall defect. So every time, so it will be depending upon the bone loss. If it is advanced bone loss, this osseous resective surgery is not recommended. So if it is it will be depending on the depth, width, and general configuration. Okay, and in case of 2-wall defect, there is a too shallow and wide or narrow. Deep, that is, it can be either receptive or regenerative depending upon the width and the depth of the bony defect. Okay, 3-wall defect, definitely it will be going for regenerative procedures. So means 3 walls are present. Okay, so coming to the other types of osseous defects that need osseous resective surgery, that is osseous craters, reversed architecture, bony ledges, furcation defects, exostosis or tori, bulbous bony contours. So this is all the details we already covered in the previous chapter. So I am not going to the details of it. So coming to the procedure directly, what is osteoplasty we already covered, and what are the indications for osteoplasty? So the osteoplasty, as we know, that is just a reshaping of the bony contours. So the indications are intra-bony defects adjacent to edentulous ridges or tilted molars. Some amount of reshaping is needed that way we can do for this osteoplasty. Incipient furcation lesion, that is in grade 1 furcation involvement. For furcation plasty, you can just go for osteoplasty just to make it accessible to oral hygiene maintenance. And for in case of shallow osseous craters, you can go for it. Flat interproximal areas, enhanced flap placement with improved alveolar contours, and then in case of buccal or lingual, bony ledges or tori. Next, in case of osteotomy, there is a procedure to remove the bony defects with the removal of supporting bone. So in case of elimination, so where the other case it was just the shallow craters for shaping. In this case, it will be eliminating, and if the intra-bony defect is not available to regeneration, we will be doing that. Then horizontal bone loss with irregular marginal bone. So you can see the difference between two procedures, and here it will be like moderate to advanced furcation involvement. So we will be removing it, not for just grade 1 incipient furcation involvement. And here for hemiseptal defects, we need some amount of for the removal of tooth. So we need some amount of bond removal and sufficient bond remaining for establishing physiological bone contours without attachment compromise. So if there is without compromise, if we are able to achieve physiological contour, you can go for the sufficient bond removal. And in case of no aesthetic or anatomical limitations also, we can go for the bond removal. So coming to the contraindications of osseous resective surgery, as we told before, deep osseous craters, 3-wall osseous defects, moderate to deep circumferential defects, aesthetic zones, existing tooth mobility, risk of root caries is considered high. If in cases where it is considered high, and in case of uncontrolled roots hypersensitivity, and also in cases it is contraindicated for surgery, there is inadequate plaque control, non-compliance, medical history, this is also contraindicated. So for all indications and contraindication, you can just try to learn at least 5 points. Okay, so coming to the advantages and disadvantages of these procedures. Advantages is it is very predictability. It is very predictable, isn't it? Predictability is the best advantage of osseous resective surgeries. It is it predicts or it attains the removal of pocket fully. Okay, and complete elimination. That is what we told. There is a complete elimination of periodontal pockets, obtaining ideal bone form. Okay, and what are the disadvantages? So there will be loss of valuable supporting bone, and gingival recession can occur, and often lengthy, unpleasant post-surgical recovery. Since it is removing the bone, it can lead to swelling, pain, and also the post-surgical mobility. So if we are doing it in the wrong way, or in case of advanced periodontal disease, if we are going for osseous resective surgery, it will lead to mobility. Factors in the selection of resective osseous surgery: depth and configuration of bony lesion to root morphology and adjacent tooth, location and type of bony defects. It should be less than 3 mm of intrabony or hemiseptal defects. There is extent of attachment loss, aesthetics, amount of bone, response to phase 1 therapy, and also prognosis of the overall condition. So these are all the factors should be kept in mind before selecting the resective osseous surgery. So coming to the examination and treatment planning, the main important thing is that careful probing, which helps to get probing pocket depth and base of the pocket related to mucogingival junction and attachment level on adjacent teeth, and will be able to get bony defects and furcation defects. And also radiographs will help you to find out, and also the response to initial therapy is needed to plan the treatment, and also patient compliance is needed. So always is for examining, always it is needed to have transgingival probing or bone sounding. There is a probe should be walked along the tissue tooth surface so that the operator can feel the bony topography. So this can be passed either horizontally, that is through the tissue, to provide three-dimensional information regarding the contours, thickness, height, and this can be done with vertical way also to find out the configuration, and this will help you to get the uh, to delineate the thickness of soft tissue, the extent and configuration of the alveolar bone, and existing periodontal defects by the use of the probe. So this by the horizontal way and the vertical way. So this can be done immediately before the surgical intervention. Okay, and the treatment planning will be based on mainly to control active periodontal disease and the correction of deformities. So coming to the armamentarium, instruments needed for osseous resective surgery, we have rongers, carbide round buds, we have diamond buds, interproximal files, it is called sluger, this is the curved one, and as a straight one is the sugarman file, and this is the back action chisel. There is a cutting edge will be towards back, and then there is the ocean beam chisels. There is a pair that is to the other side, mesial and distal. So these are the instruments needed for resective osseous surgery. Coming to the sequential steps suggested for resective osseous surgery, so to get approached to the bone level, we have to have the removal of soft tissue, right? So this different flaps are available. So out of this, the most preferred one will be the apically displaced flap. Okay, you can see that the displacement of flap apically, so that you can go for the either osteoplasty or ostectomy, and then you can increase the attached gingiva, as well as you can get access to the access to oral hygiene maintenance. Okay, so if full thickness epically position flap is elevated, then the following steps of resective osseous surgery conducted. What are the steps to be done? So not all steps are necessary in every case, but a sequencing is necessary to expand it, the reshaping procedure, as well as to minimize the unnecessary removal of bone. Okay, so always it is not mandatory to go for every procedure, but you can sequentialize or order the procedures. The first one, that is vertical grooving, and the second one is radicular blending, and this third one is flattening interproximal bone, and fourth one is gradualizing marginal bone. Okay, out of this vertical grooving and the radicular bending, mainly the osteoplasty. So just the shaping, they will not be removing the supporting bone, whereas these two procedures are ostectomy. Okay, so coming to the details of each procedure, first one, that is the vertical grooving. So what do you mean by this vertical grooving? That is, that is grooving is made vertically. So there is the interdental areas. Okay, so that is to reduce the thickness of alveolar housing and to provide a relative prominence to the radicular aspects of the tooth. So that is to reduce the thickness and to give more prominence for the radicular aspects. Okay, so this provides continuity from interproximal surface onto the radicular surface, especially in case of tooth setting, and we will be doing a festooning. Okay, that is to reduce the buccal and lingual thickness of bone interdentally. Okay, so for that we will be using with rotary instruments such as carbide bars or diamonds. Okay, with high speed handpiece and with a copious irrigation. Okay, so this is indicated in thick bony margins, shallow craters, class 1 and early class 2 furcation, and other areas that require osteoplasty and minimal osteectomy. So where the areas where these shallow areas, thick margins to get vertical grooving. So this will be contraindicated in areas with close roots and thin alveolar housing. You cannot do. So there is thick body margins or shallow craters, class 1 and class 2 furcation involvements, and other areas that require just more osteoplasty and not osteectomy. So especially we are doing the festooning of alveolar bone. Okay. So this is the procedure. You can see that thickened bone here. So the flap has been raised and you can see the thickened bone and the craters, shallow craters. So this vertical grooving has been done with carbide bars. See? So this is more clear with this diagrammatic representation. So coming to the radicular bending. What is that radicular bending? So that you know that is always it is a second step. This is an extent of vertical grooving. So we have always made we have made this there is the radicular prominence with the vertical grooving and we have to blend it. Okay, so this is an attempt to blend the bone over the entire radicular surface to provide best results from grooving. So especially we are attaining the smooth surface for good flap adaptation. Okay, so indications are same like before, that is a shallow craters, thick body margins, then only we will do vertical grooving. So this will be continued after vertical grooving. There is a radicular blending. Okay, and this will be contraindicated in cases if vertical grooving is very minor and or if the radicular bone is very thin and fenestration is there. Okay, so that is especially for thick ledges and for class 1 and early class 2 furcation involvements will be treated with this both procedures, that is vertical grooving and radicular bending, especially the osteoplasty. So this is the radicular bending as I told before, that is we are blending the bone over the entire radicular surface. So this can be used to do the radicular bending and this is the end result after radicular bending. So coming to the third step, there is the first step under osteectomy, there is a flattening the interproximal bone. So which requires the removal of small amount of supporting bone. So this will be removing the flattening the interproximal area, that is a thickened area. So it is indicated when the level of interproximal bone varies horizontally. So if there is irregularities in the interproximal bone, that is with the interdental bond, then we will make it smooth and remove, that is the flattening of interproximal bond. So this is indicated in case of one wall interproximal defects or semiseptal defect or coronally placed defect, but one wall edge of a prominently three wall edge. Okay, so this is contraindicated in areas with interproximal craters or flat interproximal defects and large one wall defects. This is not recommended. Okay, if it is a flat, then not recommended. If there is irregularities in the interproximal bond, that is, we will do the flattening of interproximal bond. That is basically the rationale behind this procedure. So you can see that this is the irregularity in the interproximal area. That is these areas, and you can see that. So this can be done with horizontal grooving, or there is the scribing. You can use a scribing method. There is the flattening of interproximal bone. Okay, so there is with the files we can go for the removal. Okay, So next coming to the last step, that is the gradualizing the marginal bond. So then we are moving to the gradualizing the marginal bond. So you can see that this bond removal is necessary to provide a sound regular base for the gingival tissue to follow. So we have removed vertical grooving, radicular bending, we removed the flattening of interproximal bond. Then coming to the marginal bond, there is a smooth adaptation, flap coaptation. This is very important. So in case of removing the widow peaks, you can see that widow peaks, there is a discrepancies. There is a bony discrepancies. You can see that this amount of this peak type discrepancies that should be removed for proper flap adaptation. Okay, this requires gradualization and blending on the radicular surface. It is preferable to use hand instruments such as chisels and curettes than rotary instruments because this is very fine removal. So with the rotary instrument, we cannot attain that type of fine removal or precise removal. So you can use like hand instruments more compared to rotary instruments. Okay, so it is mainly indicated to remove widow peaks. There is a small bony discrepancies on the gingival line angles. Okay, so this is all together all the procedures. You can see that the first one, there is the thick bony margin. So the craters are there. So we are making vertical grooving. Okay, towards up and down with the carbide bulbs. We are grooving it, and now we are blending over the root surface. So that is also just shaping. Then ostectomy, we are flattening the interproximal bond. So we are flattening with the interproximal bond along with the radicular blending, and then the fourth step, that is the gradualizing the marginal bond. So this is the final result we are attaining after this. So this is diagrammatic representation. This is the clinical picture. You can just go through it. Okay. So the procedures have been explained under this. So you can go through it. So these are the steps and what are the instruments used, what are the indications and contraindications. This is just a summary of all the procedures. So if you want to revise all the things in one step, you can just go through it. Okay. So in what areas it will be done, in what are the indications. If you want to make it out in each step, you can go like this. Okay, so you can use this flow chart to learn. So coming to the flap placement of and closure. So after the procedure, we have to place the flap back. So this may be replaced to either original position and to cover the new bony margin, or this can be apically positioned. Okay, this cannot be placed coronally. If it is placed coronally, again the pocket depth will be created. So this can be either at the original position or apically positioned. Okay, so if it is below, then it will be like if it is below, then you can attain more amount of attached gingiva, but it is not ideally recommended because with the bone removal, again it is going apically. What happens? It lead to post-surgical bone resorption and increased patient discomfort. Okay, so that is positioning the flap to cover the new margin minimizes the post-operative complications and results in optimal post-surgical pocket depths. Okay, so for the maintenance, you can advise to go for soft, super soft brushes with chloroxine adherents, and the attachment of flap to underlying bone. So there is the or attachment. It will take to 14 to 21 days. With the maturation and remodeling, can continue up to 6 months. So we are telling about all the attachment, regeneration, and all, and wait at least 6 weeks. If you want to go for restoration, week at least 6 weeks for before dental restorations. And then coming to the specific osseous reshaping situations. So in some situations, you need a specific type of osseous reshaping. For example, osseous craters with faciolingual ledges and one wall differ adjacent to edentulous margin, and in the case of arcation involvements, exostosis or tori and ledges. So these are the special cases that we need osseous reshaping. So we are dealing with osseous craters. Did you know that specific type of osseous shaping needed for this osseous craters? This is a very common defect. Reduction should be made to remove least amount of alveolar bond to provide a satisfactory form. So they prevent the therapeutic invasion of furcation, blend the contours with adjacent tooth. So there is this area, interdental area. You can see that this can be removed either this way or this way or this way. So this is the shaded part is the bond to be removed. Okay, so this can be attained in so this the technique that reduces the least amount of supporting bond. So that is why we are not following the whole step. So in case of this osseous craters, you can follow any of this pattern for proper periodontal maintenance. Okay. So in case of one wall differ adjacent to edentulous region, you can see that this is the surface. There is a angular bone defect mesial to the tilted molar. You can see that some amount of tilting of tooth. There is a replacement of missing teeth. It can lead to the mesial shifting of the posterior molar. So this will create some amount of defect. So this can be done by, there is a procedure called ramming. Is just nothing. There is the sloping surface connecting two levels. So here one point and here one point will be made and then connecting it. So that is called ramping ramp. So that is surface connecting two levels. So the selective reduction of bony defects by ramming the bond to the palatal or lingual to avoid involvement of the furcation has been advocated by Oceanbean and Bohannan. Okay. So this procedure ramming was introduced by Oceanbean. That is for a careful removal of bond. That is, it's very clear with this diagrammatic representation. Okay. So then coming to the furcation involvement, you can see that here for furcation involvement, you can see that it is that is like shallow grade 2 furcation. So that is horizontally it has then vertical component. So thickened bone margin. So for proper flap closure and the removal of furcation, we need to go for ostectomy. So you can see that apically displaced flap and this reshaping done. You can see that reshaping done with all the procedures. You can see that here vertical blending has been done. Okay, vertical grooving has been done and then radicular bending and also this removal of bone. You can see this normal physiological form and then finally the closure of flap. In case of ledges, you can see that there is a thickened plateau margins. There is interproximal craters. If it is with thick ledges, you cannot uh, maintain proper maintenance. So for this, you need grooving. There is vertical grooving as well as horizontal grooving as well because it's a very wide area. There is the space between two teeth are wide, so that is very wide, so we can go for horizontal grooving. So after horizontal grooving complete, you can go for the vertical grooving as well and then radicular blending, otherwise called for this very thick margins and it is wide, it is also called as spheroiding. It's basically nothing, it is just the technique of radicular blending, the result. So then if it is complete and then we are scribing. Scribing, as we told, that is the flattening of interproximal bone along with the gradualizing the bond, marginal bond and then the final ostectomy. Okay, so you can go through the procedure and there is a final outcome after ostectomy. So then coming to the exostosis or tori, there is the bulbous bony conduits that you can see here. So in this case also you cannot go for this ideal technique, ideal sequential order of vertical grooving. So this thick bulkiness has to be removed first till this point and then you can go for the vertical grooving, radicular bending and then uh, flattening of interproximal bone and gradualizing the marginal bone. So you can see that this is for the buccal area, and this is for the tori. So tori are the margins before, and this is the result after. So these are some of the rules to be followed when you are doing resective osseous surgery. You can just go through it. It's not there to by heart or anything. A full thickness mucopharyngeal flap should be used whenever osseous resective surgery is contemplated. The scalloping of the flap should anticipate the final underlying osseous contour, which is the most prominent anteriorly and which will be decreasing posteriorly. The scalloping of the flap should reflect the patient's own healthy gingival architecture. The degree of tissue and bone scalloping is reduced as the interproximal area becomes broader as the area of bone loss. Rule 3. Osteoplasty generally precedes ostectomy. Osseous resective surgery should whenever possible result in a positive osseous architecture. High-speed rotary instrumentation should never be used adjacent to the teeth and should always be used with a generous spray. The final bony contour should approximate the expected healthy postoperative gingival form with no attempt to improve on it. So the outcomes will be the endpoints of osseous resective surgery are minimal probing depths and a gingival tissue morphology that enhances good self-performed oral hygiene and periodontal health. The endpoint of osteoplasty used in conjunction with a modified Whitman flap or an epigrade position flap is the enhancement of tissue placement and adaptation at the time of suturing. The endpoint of ostectomy used in conjunction with an apically displaced flap or a thinned parietal flap is the elimination of an intrabony defect. So conclusion, remains as a very productive surgical option when the main treatment objective is pocket depth reduction, and the goal is to establish contours that existed naturally with the assumption that this will facilitate hygiene and long-term maintenance. Thank you.